Hi, good evening, everyone. I'm Dr. Ngu, the moderator for tonight's webinar. Thank you for tuning in to our first MMA Men's Health Committee webinar for the year. And some of you may be aware, the Men's Health Committee is still in its infancy, having just been established just under 2 years ago. And as the committee chairperson, I strongly encourage all MMA members across all disciplines to join us in promoting the men's health agenda. So for tonight, we will kick off one of two consecutive webinars, and I have the pleasure in introducing Dr. Umadewan Kanapati, a colleague of mine, a urologist based in Hospital Sultanah Aminah, Johor Bahru. He will be sharing with us on the topic of overactive bladder, practical updates for everyday clinical practice. So a bit of about Dr. Umar's background. Dr. Umar graduated with first class honors from the Nizhny Novgorod State Medical Academy and went on to obtain his MRCS from Ireland. He later completed both his Board of Urology and FRCS in Urology from Glasgow, again with first class honors. Dr. Umar underwent his urology training across several major centers in Malaysia, including Johor Bahru, Sabah, and Selayang, gaining broad experience in both general and subspecialty urology. He has a particular interest in male sexual health, especially in the areas of infertility and erectile dysfunction, and he is actively involved in advancing urology education through more interactive and practical teaching approaches. So Dr. Umadewan has also played key roles in organizing multiple national urology meetings and courses, including the Malaysian Urological Conference and various urology update programs. Academically, he has contributed to numerous publications and presentations with work featured in BJU International, and he has received several awards at both national and regional levels. So members of the audience, you are welcome to pose any questions from all of you, and please type in your questions into the chat box facility, and Dr. Umar will try to respond during this webinar. Failing that, you can also email your questions to him, and the email address will be shared at the end of the presentation. For CPD points, the points will be will be provided to all registered participants within 7 working days, and there's no need to scan any QR code for this presentation. So let's then welcome Dr. Umadewan Kanapati for his talk on overactive bladder. Dr. Umar, yeah.
Good evening, everyone, and thank you, Mr. Ngo, for such a kind introduction. Not forgetting MMA for giving me this opportunity with this new branch of Men's Awareness Committee, and I'm really proud to be the first one to give the talk today. So, as what Mr. Ngo mentioned earlier, if any of you guys have any questions, please post it on your chat box, or you can also email it to me, then I can explain it to you later on. We'll have the webinar today in a light and easy mode. So I don't want to make it too heavy. If at all anything, please stop me along the way, then we can have our discussion. Okay, so today's topic that was given to me is overactive bladder, and I'll be explaining regarding practical updates for everyday clinical practice. So firstly, before we would like to move on, I'd like to say that I have no conflict of interest to declare in this webinar. There's a lot of drugs and medication and procedures I'll explain later, and I'm not being paid for any of them, so please don't take it seriously. Yeah. Okay, first of all, let's see what is overactive bladder. As you can see, the name overactivity means anything that is more than norm. It's extremely active. So here you can see on my right, okay, let me take the laser pointer. Okay, see, this is a normal bladder. So what happens is when the urine gets filled up, so the detrusor muscles contracts and the urine gets expelled. However, in overactive bladder, what happens is when the urine doesn't reach the full amount, the detrusor muscle has misfiring and it contracts halfway or midway or towards the third quarter of the filling, and this causes the patient either to leak or to have the sensation. And why this overactivity is such a burden, because you can see in this phase, this is what we call it as a maturation cycle. Most of our days is in a storage phase. Like you don't go to pass urine every hour. Your voiding phase is only 1 minute, and your storage phase is the rest of 23 hours of it. And when there's an overactive bladder, you have to pass urine more than sufficient time, and this bothers your life. So coming back to the components of OAB, it consists of three main parts, where urologists like to call it FUN, frequency, urgency, and nocturia. So we'll go with urgency. Urgency is some sort of a desire to pass urine that you can't defer. So what is the difference between normal urine sensation to pass urine and urgency? So normal sensation to pass urine, when the timing and the place is suitable, you can go and pass urine. However, in urgency, you have to pass urine immediately and you cannot defer the sensation. Frequency is a little bit more difficult to be defined. In the guidelines, it's defined as 8 times in 24 hours. However, this definition fulfills normal fluid intake. So if you drink more water, probably you're going to go more than usual. So the frequency here is defined increased number of normal micturition compared to your usual routine. And nocturia, any wakening up at night or during your major sleep cycle is counted as nocturia. And more than twice, it's counted as significant nocturia. So here you can see two subtypes. Either they are wet OAB or dry OAB. As the name here, wet means it's water, so there's urinary incontinence, there's a leakage of urine. And dry means it's more of sensory problem without any leakage of urine. As you can know, OAB usually associated with female gender only, but we know here men and children or other patients are also equally exhibit these symptoms. And among men, 3 out of 4 men presents with OAB symptoms are misdiagnosed as BPH. As you can see, both OAB and BPH causes the similar complaints. They have frequency, they have urgency and leakage. So what happens is they tend to be treated for BPH rather than the OAB, which is the main problem of their concern. So what can cause OAB? Before we go into OAB, let's see what is bladder overactivity. As I defined earlier, anything that heightened activity is counted as overactivity, and there are multiple conditions here can actually increase activity of the bladder, can give rise to the similar symptoms. So OAB, it's the symptoms with no proven infectious or other obvious pathology, means it's idiopathic. There's no other cause that lead them to have this complaint and these issues. So you may ask, why this OAB is so important? What do they bring? So almost all consistent studies have shown OAB symptoms makes patients to sleep less, their productivity decreases, their mental health decreases, and they exhibit more depressive symptoms because they cannot get a good night's sleep, cannot work, and they also exhibit a lot of issues with their partner's sexual dissatisfaction. On top of that, there's a systematic review in 2014 and 2018, which shows there's fractures with overactive bladder. So what happens is when they have more than one episode of them going to the toilet, they get the toilets might be slippery, or maybe they are not getting enough sleep, or maybe they are dehydrated, and this causes them to fall. And you can see at least one fall over a year. This fall could be anywhere. It could be a minor fall or even a serious fall, up to 50% of patients complaining of this. And the risk of fall is higher among women and above 65 years old. So knowing the importance of OAB and the pathophysiology, now the question is, how do you know if your patient has OAB? It's not that easy as you think. OAB is easily diagnosable. Let me show you a few things where you can take points and skills and tools that you can use. So this is a flowchart that I have created. As usual, as any patient that presents to you, first thing of all, you need to take a very good history. You need to know patient's age, their medical conditions, medication, and lifestyle. This will roughly tell you what is the main issue with the patient. Either they have a storage symptoms or they have avoiding symptoms. The next part, you need to check their patient's meatus. For men, they will have meatal stenosis or stricture, so sometimes enlarged prostate, or in obese patients also can present with the OAB kind of symptoms. And then you go on to the test. So the test starts with the bladder diary. Later on, I will show you the bladder diaries. Urine FEME to rule out infection, renal profile to rule out renal impairment, and ultrasound. It's not necessary, but if you're suspecting something more sinister, then you can do an ultrasound. Uroflow and UDS are done in more specialized centers, like in urological centers. So if you have done the basic investigation, history and physical examination alone is enough for you to diagnose OAB and can start treating the patient. So this is what I've mentioned regarding bladder diary. So bladder diary is defined as intake and output of fluids per person per day we usually tend to do for 3 days in consecutive days. In general, usually we'll ask about what are the type of fluids they are taking, how much they are taking, and about their urination pattern. How many times they went to pass the urine? Did they have an urge to pass urine? Was the activity got interrupted? And if they have any leakage, did they have a small amount, a large amount? This is all based on patient's own complaint. Okay, and for those who are not so literate, we have a little bit more easier bladder diaries with pictorial explanations. Here you can see like what are the drinks that they're drinking and the urine, how many times they're going, and if they are leaking, then you can show them whether they are small amount, medium amount, or large amount. This is much more easier for elderly patients or those who's a little bit difficult for them to understand a bladder diary. Bladder diary is a compulsory thing that you need to do in order for you to diagnose patients with OAB, because your frequency, your urgency, and nocturia can be all objectively assessed in this bladder diary. And this can be, you can download any of this bladder diary. You just have to go to Google and then you find bladder diary. It's everywhere. They're almost the same. You just have to have one of them. The next part is Euroflow. So Euroflow is a specialized test that performed mostly in a urological center. You can see this machine here. It's called as a spinning disc. So when the patient passes urine, the disc will measure the weight of the flow. So here you can see this is what we call as a normal bell shape. So it has a normal up trend and then it goes down with a good amount of time. If you see here in patients with overactive bladder, because they've been holding the urine for so long, the moment they start passing urine, they go for high peak and then abrupt drop. It's a short period of time, large amount of volume. This is typical for uroflowmetry. In certain cases, we would prefer to do a urodynamic study. Urodynamic study, to put it in a easier way, it's more like an ECG for the bladder. So it has a special catheter for the bladder pressure monitoring, abdominal pressure monitoring, and specific tests that we do. So here, I'm just not to confuse anyone, I'm just showing a normal picture. You just have to look at this green line. Green line here in the picture B shows like the bladder activity. You see a flat line. It doesn't show any activity at all. This is a normal good bladder. However, if you look at picture A, you can see a lot of movements. They are not related to the abdominal movements or other movement. They are purely because of bladder in overactivity. And this overactivity is associated with some leakage. So we don't do this urodynamic for every single patient. We only advocate this urodynamic in those patients who we think are refractory to initial treatment or whom we think it's a little bit like, in between of this and that. We are not sure about the exact diagnosis of the patient. So I think would be the most important slide of my presentation today. I've summarized three main guidelines that we use to treat OAB. So we have a European Association of Urology, we have NICE by UK, and American Urological Association. So all three guidelines have similar recommendation on how to treat patients with OAB. So you can see I have color coded them into green, yellow, and red. So the green part comes with behavioral therapy. The second part, the yellow is medication, and the third part are more invasive. So we'll go through them one by one to let you know what are the options that we have. So first part, behavioral therapy. So behavioral therapy mainly consists of either a cognitive and a bladder retraining part. So what happens in cognitive is mainly about focusing and self positive talk and visualization. So whenever the patient have the symptoms to pass urine, you have to advise them to practice certain methods which ease their urgency, so deter their mind. Some even go for drawing, some tends to read books, some listens to music, whatever that works for them. So this distraction technique is a part of bladder retraining. So what is your goal in the next 6 to 12 weeks? You just have to defer. Maybe you start with smaller amount, no need to be 15 minutes, maybe you start with 5 minutes, or in certain cases, maybe you can even start with 1 or 2 minutes. So what you have to do when the sensation arises, you try to distract yourself for 5 minutes and you try to do it for every single time the sensation happens. And as you progress, same goes to any other, training and methods. You can slowly increase the duration from 5, 10 to 15 minutes, trying to reduce that sensation. And the third part is pelvic floor strengthening. For Kegel exercises for men, there are multiple different types of Kegel exercises for men that can be done. You can search them in online. You can advise the patient. Mostly the one that we advise them is a hold and release technique. So when they have the sensation to pass urine, they just simply have to squeeze the anus to contract the pelvic floor muscles, and they can continuously do this over and over on different occasions wherever they are, as long as they are comfortable. So the blue box here is a very important part of a our practice, we urologists, we tend to follow a certain recommendation, and this recommendation is from European Association of Urology. You can see prompted voiding, bladder training, and pelvic floor muscle training are very strongly recommended, and they define the basic treatment of patients who presents with OAB. They are not only certain specific for male alone. It generally works for all age groups, but here I'm just highlighting for men's management. The second part is a nerve stimulation, or also called as electrostimulation. So here we have two different techniques. The first one is a tibial nerve stimulation. So we have this special device, it's called as a PTNS. It has an electrode which is connected to the ankle, and the ankle gets stimulated. So what happens is this nerve technically modulates the sensation of urination. And the second part of it is a little bit less invasive electrodes that placed around the perineal area. It gives sensory impulses to allows the patient to do more controlled area of physiotherapy or some sort of exercises. This is more like a biofeedback kind of workouts. And coming to medical management, before we talk in detail, we need to understand the normal bladder pathway. So we have two main control system of the bladder. We have parasympathetic control and sympathetic control. So parasympathetic control mainly by M3 muscarinic receptors. So what happens is when acetylcholine gets binded to the receptors, it causes contraction. For sympathetic, it works the other way. When the noradrenaline binds to these receptors, it induces relaxation. The medication works on opposite. So for the parasympathetic blockade, what happens is they block these antimuscarinics, and this leads into inhibition of contraction and bladder gets relaxed. For adrenoreceptors, they are actually agonists. When they bind, they activate and they induce relaxation. So both gives different mechanism of help in patients with OAB. So for antimuscarinic, it's mostly delayed voiding because you increase the capacity of the bladder. For beta-3 agonist, it actually increases intervoid interval. So here you can see from 1960s to 2021 and 2023 and so on, we actually have evolved into different type of medications. So initial part of it are just general antimuscarinic, they are called as non-selective. And once in 1997, they invented the term of overactive bladder. We went to more specific group of antimuscarinics, which targets on mainly on bladder alone. And in the recent years of 2000 and above, we have beta-3 agonists, which are mirabegrone, solifenacin, and all. So here you can see like few of the common combination of medication that we have: vesicam, trospium, oxybutynin, tetracytol. And in this, this is a transdermal system. So on those patients who complains of difficulty of taking the medication orally, they can also opt for thermal patches, which work equally as good as the oral medication. And these two, vibegrone and mirabegrone, are the little addition to this group of family. Again, going back to our guideline, what the guideline says, it says we're still going on with the anticholinergics. So the top group says, number one, if they are ineffective, you can either consider a dose escalation or you can add on this medication, the second type of medication. So everything comes with its own risk. Like you can see here, if you're starting the patient with antimuscarinics, you need to be ready to deal with the adverse effects. So since they are anticholinergics, mostly they are related to anticholinergic effects like dizziness, drowsiness, constipation, and most of the patients will complain about dry mouth. In elderly patient, you need to be careful because it also have shown that antimuscarinics have lead into memory loss, and in some patients, it also can cause memory deterioration. And adverse events are the most common cause of non-adherence to antimuscarinics. About 60% of patients complain some sort of side effects, and they couldn't continue the medication because of the side effect that they experience. Talking about it, Batmiga doesn't come with most of the general side effects like the anticholinergics, but it also has other issues such as hypertension. So in patients with renal impairment and hypertension, Batmiga cannot be used. So going on with the next modality, which is a surgical management. Surgical management is the easiest. There are few least invasive and the most invasive. Botox, as you all can know, it's not only used for face, it does not beautify face alone. It also beautifies the bladder. So later I'll show you how does it work. So similar type of Botox, we use this botulinum toxin type A. And you can see this study A and study 2, which are also tried with Botox. It shows significant improvement in patients' symptom score by introduction of Botox. So how does this Botox is being injected? You can see in this picture. This is a video of mine. Okay, so these are the target points of where we're going to inject the Botox. So we will pre-plan them 1 cm apart. So we'll do a cystoscopy. We'll identify the urethral orifice. So we'll examine the bladder, make sure the bladder has no any suspicious lesion. The bladder looks normal. And then from that point, we'll have this special needle. It looks big here, but it's actually just about 18 gauge needle. So we'll inject into the mucosa of the bladder, and you can see the mucosa pale, means the medication gets introduced into intradetrusor or submucosa. So you can see the blood is rising up. And you will repeat this process into the points that I've shown you. Usually we inject about 20 points, sparing the trigones. So we inject here. The only thing that we have to be careful here is not to inject into the vessels, because most common side effect of this Botox is bleeding. After the injection, you can see the needles are quite sharp, and sometimes we can see they can go quite deep. We can adjust the depth of this needle based on the thickness of the bladder. And another issue is some patients, after injecting the Botox, the bladder relaxes too much. They fail to void. They might need a temporary catheterization or either a continuous self-intermittent catheterization. So these things you need to explain to the patient before you start them on this medication. So, and the next part of it, slightly advanced. This works the same as the earlier PTNS that I have mentioned. It's called as neuromodulation. So what happened here is, this video I've taken it from Medtronic. So here it works mainly on sacral nerves. So sacral nerves are in the most important nerve that controls your micturition cycle. So the implant will be placed at your sacral nerve root, usually in S2 and IS3. So it causes depolarization of this nerve. This prevents progression of a new impulse. So the machine gives the first action potential. The nerves get depolarized. So when you have that sensation to pass urine, it doesn't get transmitted to your body. And this would be the most extreme end. Used to be one of the famous method in the last centuries when we didn't have much of the medication. So what happened is we take a segment of bowel, and then we bypass the bladder, and we patch this bowel on top of it like a cake. So with this, the benefit is you get an extra reservoir. So this is technically reserved for those patients with very small contracted bladder with small capacity. So this helps to increase the bladder and those fibrotic bladder where your Botox and other medication does not really work. Nowadays, I don't really see patients getting this kind of treatment for OAB per se, but in other conditions, in pediatric groups and in neurogenic patients with overactivity, we are still using this method of management. And as you can see, any big surgery comes with a lot of complication. And here you have anastomosis, and then bowel healing and capacity, mucus production, infection. There's a different level of complication to be managed for this patient. So going on, I think this is common nowadays. It's not like last time where any treatment plan that we are planning to give for the patient, we need to make a decision with the patient themselves. We have to ask them what are their interests, what are their goal, and how can we help them to achieve their goal. Everyone has different type, of course, and like I mentioned earlier, there are different modality of medication, treatment, surgical intervention. So each one of them decide on how they would like to be treated, how bothersome are the symptoms, and how aggressive should you go. And you can use these easy steps that I found. I call them SHARE. Like the mnemonic here, you can see SHARE, and from here you can decide what will be the best treatment option you can provide for your patient. This is just a small slide that I would like to highlight here. As you can see, urinary incontinence in men is less likely to be diagnosed and treated because most men has stigmas of either reaching out for help, or they feel emasculated when they complain to someone that's saying, oh, I'm having these complaints, and also they tend to come at a very later stage. So if you have any patients who comes to you about urinary problems, try talk to them and ask them about urinary incontinence. I think it is a bit of a sensitive topic to discuss, but if you give them the option to talk about it and you educate them, I'm pretty sure you can catch more than enough people who've been suffering with this condition and we can treat them effectively. So this is my last slide for the today's presentation. I would like to highlight to you, you are not alone in managing patients with OAB. Every urology center is there to help you out, to guide you if you ever needed any help or any suggestion, recommendation, how to tailor to patient. Or if you have any questions or anything, you can always approach me. You can email me at umadevan.moh@gov.my, and I'll be more than happy to answer your questions. I think that's all for my topic today. So any questions?
So thank you, Dr. Umadevan, for the very enlightening presentation. I'm sure members of the audience agree that OAB can be a very debilitating condition, yet it is very treatable as well in most cases. Unfortunately, it is also common for this condition to be brushed aside as a trivial problem, but somehow I find that the physical and psychological effects are rather profound, especially in dealing with wet OAB. So, Dr. Umar, you have highlighted the stepwise progression in managing OEB. In your experience, how effective is behavioral or lifestyle modification therapy?
To be honest, Mr. Mo, I think this behavioral therapy comes like really important. I think it comes with educating the patient themselves. Firstly, you need to identify the risk factors. Like most of the patients have this habits, I would say, caffeine, smoking, alcohol, spicy food. So when you take these things away, almost half of them get immediate response to the condition. They do not know that these things are like, leading them to these symptoms. And the second part of this bladder retraining, it works like a magic if they actually follow. You just have to tell them, like, you have to consistently do it. The issue is they will start doing it in the beginning of their condition, and as time passes by, I think as anyone else, they get tired and like, oh, I'm just lazy, and they opt for other things. If they do it diligently, I think it works like a magic. 70 to 80% of the patients responds well with this behavioral and bladder retraining alone.
So, what I can gather from your explanation is that simple things do work actually. Yeah, we don't have to progress onto
Yeah.
pharmacotherapy. So, I'm going to pick up a few questions from the members of the audience. I have a question here. A common point of confusion in primary care is whether overactive bladder and urge urinary incontinence, do they refer to the same condition? Could you clarify the distinction between the two and explain whether differentiating them changes management in clinical practice? Yeah.
Oh, this is a really a tough question to answer, because when the patient presents to you, they tell you similar symptoms. They'll tell you about urinary incontinence, they'll tell you about frequency, they can tell you about urgency and nocturia. This package, like I mentioned earlier, they are symptoms of bladder overactivity. They do not mean OAB per se. So you need to identify, is there any other cause that might lead into this condition? It could be underactive bladder, it could be overflow incontinence, it could be stress incontinence. So that's where we come in and we check them. We ask them, where does this leak exactly happens? Is it associated with only urgency and incontinence, or is it a mixed incontinence? And you'll be surprised, most of the patients, they usually have something else that bothers them, and urinary incontinence, urge incontinence is just like one tip of the whole symptoms. So it really takes a lot of things to, like, like I mentioned, you need to do a real proper examination, neurological assessment. Then you can come to this conclusion. It's purely urge incontinence.
Yes, I agree with you. And can you also share with the audience when should a patient be referred to a urologist? What are the red flags in a patient presenting, for example, with urgency and frequency, that should prompt them to get early referral to a urologist? Yeah.
I think here, since we have all mostly medical doctors, I think you have to trust your instinct. Like sometimes, things just doesn't fit into the puzzle. Like you see them, like like something is just not right. Like then you can already ask us for consultation. Otherwise, like what you see, like if it is associated with like bladder pain, or maybe recurrent infection, or even have hematuria, or stone history, or patient is complaining like difficulty in passing urine, all these things should already alert you that this is just not a OAB. It could be masking something else, which is more sinister.
Okay, all right. And earlier on, you mentioned in one of your diagnostic workup, there's
Yep.
a test called urodynamic study. I think for those who have not heard about it, where can the patients get a urodynamic study done? Is it a very painful procedure?
Okay, so urodynamic, like I mentioned, is like an ECG for the bladder. It literally detects the bladder activity, how good your bladder, how good is your voiding, and all those things. Now we have it in JB ourselves. We have a limited numbers of cases that we do. The one of the issue is probably the cost. We don't do it for every single patient. So patient goes like what I mentioned, my green and yellow, they get the medications, they get the physical therapy and all those things. If despite on all those things, they do not respond, or I'm going to go on for more invasive like Botox or like, something else, modulation or something, then they get a UDS. So UDS is more like to prove to me that this is purely OAB and it is not like something else that I'm missing out.
Okay, fine. So now, from a pharmacotherapy point of view, we have a few questions from the audience. So one of them
Mhm.
is goes like this. So when an adult patient presents with OAV symptoms, like what you have mentioned, without any obstructive symptoms, voiding symptoms like intermittency, hesitancy, incomplete voiding, and ultrasound shows a prostate size of probably about 30 mils, how would you treat this patient? Would you treat him as an OAB or a BPH patient?
This is a little bit tricky,
Yeah.
provided the ultrasound shows like it's a small prostate and they do not have any other issues. You can start treating them as OAB in the first initial phase, and if like any medicine, if you're treating the right thing, they should improve. So despite of your treatment, they do not improve means you're not treating the right condition. And surprisingly, OAB and BPH overlaps on a lot of spectrums, and you have to treat them concurrently instead of treating one over the another. So you have to treat the BPH symptoms and also you have to treat the OAB symptoms to get the full control. So I think this is a little bit trickier there. You can look at them and you can ask them which one is bothersome, which bothers them the most, and you start treating that, and then the subsequent one you can treat the other conditions, or
Oh,
you can refer to us to co-manage it.
right. And what about patients who have only partial response to monotherapy, who only benefit partially from monotherapy? When would you favor a combination approach, combination therapy, or would you move on to a more, perhaps more invasive treatment option?
In my practice, I take 6 weeks as my cutoff point. So provided the first phase they do it really well, like go for proper all this bladder retraining and everything as such, I will give about 6 weeks for them to be on the medication compliance and adherence. And I tend to start them with the Mira background first, then the anti-muscarinic with the recent medications compared to all the studies and all those things. And if they don't respond well to Mira background, I give them a second chance on adding on an anti-muscarinic. So that will be my combination medication. That will be another 6 weeks. So then about 12 weeks, we already know whether are they on the top form of the medication, is the medication is working. If it doesn't work, I do not increase the dose. I know some practitioners, they actually max out on anti-muscarinic, but I don't really add a maximum dosage of anti-muscarinics. I try to be on a little bit on a conservative part of anti-muscarinics.
Right, right. Yeah, and you have also mentioned the role of Botox injection for urinary bladder in OAB. So, just for the benefit of the audience, how much of Botox is actually used per
Uh,
treatment session?
Yeah, you'll be surprised. Although I mentioned the Botox similar to the facial Botox, but this
Yes.
Botox is specialized for bladder. They come in from the same family, but they are more purified version. We use about 100 units for this Botox. And however, this 100 units injection has to be repeated 6 monthly. It doesn't last for lifelong. So
Okay.
if they respond in after a 6 month of interval, they need to come back for the second round. And this goes on until the symptom is well controlled or for life. They have to be on this Botox, unfortunately.
Okay. And are there any contraindications for the use of Botox in OAB?
Yeah, so this contraindication mainly you need to check on the patient indication themselves. Some patient might have some sort of allergy and some sort of reaction towards previous Botox injection. On top of that, any coagulopathy or any active infection are also contraindicated. One of the important things that you need to tell the patient before you give them on Botox is risk of urinary retention. So, like I mentioned earlier, when you inject Botox, it relaxes the muscles too much until to the point they cannot pass urine. And there might be a certain group of patients need to be on catheter. You need to remember that this patient has no problem with voiding. They only come to you because of urgency and incomplete frequency of passing urine. And when you inject Botox and if they have to be on catheter, they'll be a little bit more bothered. So they need to understand that if you get Botox, you might go for urinary retention. And if they don't agree, And I think there is already a relative contraindication for them to be on Botox.
Okay, right. And let's take a step back. Now we're talking about Botox. We have a question here. So can you advise regards to your approach on the choice of anticholinergics or antimuscarinics, especially in the elderly population, based on the known adverse effects? And how would you tailor the treatment dosage, and how would you taper the dosage if you need to taper as the symptoms
Yeah.
improve? Yeah.
This is actually a very good question. I think this is very important for primary healthcare providers. So first thing that what you can do is there's something called as an anticholinergic calculator burden, ACB burden calculator. So you put in all the patient's medication and then you count what is the burden on anticholinergic they are already on. So if they are at a high level, it gives you a three risk category: low risk, intermediate, and high risk. If they are already anything above low risk, I don't think so. You should put them on antimuscarinic. That's the end of discussion. The second part of it is if they have already pre-existing dementia or any type of mood disorders or any memory problems, also I don't think so they are suitable to be on antimuscarinics. Let's say they are low anticholinergic burden and their memory all okay. I tend to go for tolterodine, or I will go for more of trospium, which doesn't passes by the blood-brain barrier. And my last resort would be a vesicare. And for dose reduction, usually I don't do dose reduction. I usually advise the patient to be on the medication and to control their lifestyle. And from that point onwards, and then we monitor. I know some urologists, they do EOD dosing. So the patient takes on a good day, and when they have like bad symptoms, then they take back. But it all depends on patient's perception and patient's control. It's like no hard rule that this is how you do it. But if you're asking me for elderly patient, how am I going to decide? Definitely first need to count the cholinergic burden. Second part is any issues with memory and any other contraindication. If all clear, then go for that fourth generation antimuscarinic that doesn't pass the brain barriers.
Thank you. Thank you. That's very clear. Yeah, that's very clear. Thank you about sharing about anticholinergic burden. I think this is a very important concept. Yeah, we just take another step back. There's a question from a member of the audience regarding pelvic floor exercise or Kegel's exercise. Is there any difference between how it's performed in a male patient or a female patient? Do you have any comments
I
on that?
think
Yeah.
Yeah, it's a little bit difficult to advise men to do these Kegel exercises in general because for female, I think more of a pelvic floor strengthening. Men does not have that much of a pelvic floor weakening unless they have previous surgery or something that happened to the pelvic floor. So for Kegel exercises for men is more important than pelvic floor strengthening. So if you go and search on Kegel exercises, the most commonest method they mention is a squeeze method. So when they're passing urine, they just have to hold it in, squeeze it. It's more of like clenching the butt and then you relax it. And they can, once they have already trained this sensation, they can even do it at any time. Like maybe they're sitting at home, they're watching a movie, they just have to bring it into their mind and squeeze and release. Squeeze and release is just to increase the voluntary control of this sensation. And that's the only thing that they can do.
Okay, thanks for that. Okay, there's another question that comes regards to when you are taking history and trying to diagnose OAB. So,
Yeah.
do we know that for low tract symptoms associated with BPH, for example, we have the IPSS score to assess the severity of low tract symptoms. Do you have something similar for overactive bladder specifically? And are there any tools available to differentiate between a BPH and an OAB condition?
I'll answer the second question first. I think that is much
Okay,
more easier. It's
all right,
almost impossible to differentiate between an OAB and
that's
a
right.
BPH by just symptoms alone. So
Okay,
it's very complicated than that. Regarding the tools, we have something called as a questionnaire, OABSS. So OABSS is a questionnaire that we use not to diagnose, but actually to follow up on patients already on medication. So we start them on medication and we give them a baseline questionnaires to assess how they have been responding to this OABSS, to the symptom score. I think bladder diary alone, I think is more than enough because in bladder diary, you can already see the frequency, urgency, and nocturia. Like I mentioned earlier, you have to find these three things, the most important thing: frequency, urgency, and nocturia. And with that, you can already start them on medication.
okay, thank you for that. And you also shared with us a couple of surgeries that can be done after having failed conservative measures, pharmacotherapy, Botox injection. In your experience, how effective are these surgical interventions? Yeah.
I think to be honest, I never seen a augmentation for bladder overactive bladder so far. I've seen sacral neuromodulation when I was in HKL. I've seen quite a number of patients. They respond pretty well. This group of patients who refuses to be on medication and they do not want to be on a repeated Botox injection. So that was the only group who underwent for this sacral neuromodulation. Yeah, second remuneration, it works pretty well if you can tailor the intensity and everything, but it comes with a steep price too. So yeah, you have to think about the cost on the another side of it. Other than that, I don't think so at the moment we have any strong indication for augmentation unless it's like severe OAB, never treated, and small contracted bladder. And I realize small contracted bladders are usually air contractile bladder rather than overactive bladder. If you augmentate the bladder, they technically cannot do anything. They have to be on catheter, and also that's a different topic to be discussed.
Okay. Right. Thank you very much for sharing all those salient points with us on overactive bladder. We also have a very long question from one of the members of the audience, but I think you have already highlighted the parts and answer to that question in your explanation just now. So, Dr. Umar Devan, any last remarks regards to OAB and how, in your experience from the pattern of referrals you're getting so far, any points or any salient points to share with our colleagues in primary care regards to referrals of OAB patients? Any myths that you want to debunk here? Perhaps you can spend the last few minutes and give us your thoughts. Yeah.
Yeah, sure. I think firstly, I think you guys shouldn't be afraid to ask for help. We are here to help the patient. That is the most important thing. So if you're not sure what you're treating, you do not know, you can always give us a call and you can tell us like this is a patient that I'm seeing. I do not know what am I treating. Can you give me some advice, some suggestion? We'll be more than happy to help you out. That's the most important thing that you need to know. Second, regarding the path of a referral, you don't need to wait that long actually. The moment the patient comes in, you have already done a bladder diary and you're suspecting an OAB, you can already call us to get an appointment. As you can know, our waiting list is about 3 to 6 months for non-urgent, non-onco cases. So by the time the patient comes to us, it's already 6 months. So either they have already been treated well, they are in a very good control where we can just do some touch-ups and advices, or they have not been responding well and they are coming to us on a very end of their disease. So if you can refer them earlier, it'd be easier for us to start the medication and can let them have a little bit improvement of their quality of life. And other than that, I think what your mind does not know, your eyes do not see. So I think you have to join more webinars and learn about a bit on OAB.
So there you go, ladies and gentlemen. Overactive bladder, practical updates for everyday clinical practice, presented by Dr. Umar Devan Kanapati. I'm sure there are more and burning questions, and for those who have just tuned in, Dr. Umar Devan has kindly agreed to answer some of your queries via email if you have any burning questions. Would you like to share with us again your email address, Dr. Umar?
Yeah, sure. So you can contact me. I think I'll just put it here, then I think it'll be easier for everyone to
Okay.
see. And
All right. So once again, to all the members of the audience, the CPD points will be locked in for you guys. There's no need to scan for any QR code, so don't look for any QR code in this presentation. Okay. And I'd like to thank Dr. Umar once again for spending your evening here with us. I'm sure you must be very tired after a long day in OT. So overactive bladder, very important, very commonly seen, but probably easily misdiagnosed or mismanaged as well. So thank you very much for tuning in for tonight's first webinar organized by the Malaysian Medical Association Men's Health Committee. And do tune in again tomorrow night. We will have another talk on testosterone deficiency syndrome. Thank you very much, everyone, and have a good evening.
thank you. Good night.